Ricardo. Welcome, everybody. We're super excited about the event. My name is Mark Bonica. As Ricardo said, I am both a associate professor in the Department of Health Management here at UNH, as well as the education chair for the Northern New England Association of Healthcare Executives. So wear two hats for this event, and this is a co-sponsored event from both of those organizations. So we're really glad you could join us. This is going to be a great panel, and I'm not going to delay any longer. I'm going to go ahead and introduce my esteemed colleague, Dr. Semra Aytur, to take over.
Thank you so much, Mark, and I am delighted to be here as well. I'm Semra Aytur, and I'm an associate professor in the Department of Health Management and Policy at the University of New Hampshire, and I'm also an epidemiologist by training. There is nothing that epidemiologists like more than talking about improving the health status of a community, which is why we're here today. And these four panelists are, I think, the most exciting people to have that conversation with. So we are really looking forward to this discussion today. How we're going to structure the evening is we have four panelists. I'm going to briefly introduce them in a moment, and they're going to each present for about 10 minutes. And after that, so that'll probably take up, almost an hour for the four of them to present. And then we will open it up to the interactive question and answer. So we'll have plenty of time for you to put your questions in the chat, or feel free to voice your questions to our panelists. But we do ask that you hold those questions until everyone has had a chance to present. So let me briefly read just the names and introduce our panelists very briefly. Our first speaker today is going to be Mr. Douglas Brown, who is the president of the UMass Memorial Community Hospitals and CAO for UMass Memorial Healthcare. Michael Swack is a professor at the Carsey School of Public Policy at the University of New Hampshire, and he also directs the Center for Impact Finance. He wears many hats, which we can tell you about when it's his turn to speak. And then we're delighted to have Deborah McGill, who is the Senior Director of Population Health at Maine Medical Partners. So we have representation from across New England. And then our final speaker, kicking off our relay, will be Shawn LaFrance, who is the Vice President for Population Health at Cheshire Medical Center here in New Hampshire. So again, thank you so much to our panelists. We are just very excited to talk about social determinants of health, equity, the anchor mission, and all of the different ways that we can work together to improve the health of our communities in these unprecedented times. So with that, I'm going to turn it over to our first speaker, who will be Mr. Doug Brown from UMM Community Hospitals. Thank you, Doug.
Thank you, Semra. And it's wonderful to be here to talk about this subject. I think there's probably never a more important time to talk about community health, what we've gone through, what we've learned through COVID. It's more important than ever. So I'm thrilled to be here. Mark's going to drive my slides for me. Thank you, Mark. So we can just go to that first one. You can back up one, please. Here we go. So here we go. So yeah, you can advance one. I'm going to talk to you about our anchor mission, which is a journey we've been on at UMass Memorial Health for the better part of 3+ years. I'll start by just telling you briefly who we are. We're about a $3 billion academic health system in central Massachusetts. We have an academic medical center. We've got 3 community campuses, community hospitals on a number of campuses. We have a behavioral health provider and a large physician practice. We have about 15,000 employees. So, our journey really starts with this map. When we think about the health of the community, the ultimate measure, of course, is how long people are expected to live. And if you look at a neighborhood right across from Worcester Polytechnic Institute, which is listed as Salisbury Street on this map, a baby born there today would be expected to live 84 years. That is longer than the state average. It's longer than the national average. You're doing pretty well. But if you just go 2 miles to the south in Worcester, So the same city and the same state and the same country, 2 miles takes 11 years off of life. And Kelly Square is, for some of you may know, right where the new Polar Park is, the home of the Worcester Red Sox. It all has to do with the conditions of those two neighborhoods. You'll see it Salisbury Street by WPI and what we call the West Side. The mean household income is $110,000. There's virtually no one below the poverty level. Very few under 10% on Medicaid. Almost everyone has a high school degree and a car. And if you look in Kelly Square, the situation is much different, right? About a third of the mean household income that it is in Salisbury Street, $37,000 a year. You almost have 30% of the households are under the federal poverty level, 60% on Medicaid, and almost 30% don't have a high school degree and diploma. You can't see it on this slide, but about 25% of the households in Kelly Square do not own a vehicle. So imagine the stress on one's life when that's the case. Next slide, Mark. So when we think of these conditions, you all are quite familiar with what we call the social determinants of health, which are income level, food insecurity, your access to healthy food, your job situation, your education level. And what we know is that these social determinants of health contribute about 3 times as much to our health over the course of our lives than the great healthcare we provide. And that's pretty staggering, right? And so we had a little bit of a, kind of a critical moment a few years ago. We realized that if our mission really is to improve the health of our community, how can we truly be authentic to that mission if we are not getting outside our walls and doing everything in our power to address the social determinants of health? So that's what we decided to do. Next slide. And so we adopted an anchor mission. This was a long process. I was at a conference in 2017 with our board chair, who happens to be a professor at the Harvard School of Public Health. So I had a good partner in this effort. And we heard a presentation by a CEO of ProMedica in Toledo, and they were on this journey for about 10 years. And we said, geez, we can come back and do this in Worcester. So what an anchor mission is simply a conscious and strategic effort to use the full economic power of the organization to lift up the community, and specifically to do so to address social disadvantage and pervasive inequality. Largely, as you'll see, we're not talking about spending a lot of new money. It's really just redirecting the money that we now spend in a way that is far more effective to the community. We are a national network now, a part of a number of other, what I like to call enlightened organizations who are doing the same thing. We've learned from many, we've taught many, and it's just been a great journey. Next slide. So it breaks down into 4 key areas. Hiring, we hire a lot of people in the organization. And so this is about becoming more intentional about hiring from those particular neighborhoods like Kelly Square, where there's very high unemployment rate, not the typical people we would normally hire. But when we give a job to folks in that neighborhood, we turn around lives and we turn around neighborhoods. Purchasing, we spend about $1 billion a year buying stuff, right? And some of those are kind of sophisticated medical equipment, which we're not going to be able to purchase locally. But there's a lot of things we purchase, which if we're a little bit more strategic and intentional about it, we can do so in a way that lifts up local businesses and transforms communities. Investment, I'll talk to you about how we're redirecting some of our investment locally. And then we found that, we always knew this was going to help the community. What completely shocked us was how it was going to transform our employees. And what it's done is it has it has created a huge level of engagement among our employees who want to participate and want to get involved. You know, I think healthcare employees in particular, and this was true before COVID, they were beleaguered. Now it's just at critical levels. It's just unbelievable. And you think they have no time to do this, and yet they find the time because it's work that is larger than themselves, and it's an opportunity to really give back, and it really inspires them. Next slide. So I'll tell you a little bit about our investment pillar. We pledged 1% of our long-term investment portfolio. In our case, that's $400 million. So 1% is $4 million. And instead of investing in stocks and bonds, we're going to invest that $4 million in the community. These are not grants, so it's not like your typical community benefit. These are truly investments. We're going to get the money back if we make good investments, but instead of getting a rate of return of 5 or 6 or 7%, we just want to cover inflation. So typically it's about 2%. And what we're finding is the sweet spot for us is kind of relatively short-term financing for a lot of nonprofits that are looking to line up their long-term financing, but they need some pre-development funding to do things like architectural drawings and other stuff. So typically it's, you know, $300,000 to $400,000 is our average short-term loan. And you'll see we've invested in chronic homelessness, we've made 2 investments in the arts community because we know that arts turn around communities because it brings people in. We've invested in first-time homeowner programs, in a tiny home village for the homeless in Worcester, and a creative hub. So I'll tell you a little bit more about some of these on the next slide. But, you know, of the 4 million, where we've got 3.2 million out the door. The other thing I'd mention is we merged with a community hospital. We acquired a community hospital earlier this year in July. And for the first time, to my knowledge, in the country, we built our anchor mission commitments into that merger. So we committed another $4 million to the community of Southbridge, Massachusetts, right by Sturbridge, to do some of these same investments. And the Harrington Hospital also committed to purchasing and hiring pledges like we've done elsewhere. And I'll tell you, first of all, it streamlined the regulatory process. The regulators were tickled pink with the focus we're making on the community. And it's inspired that organization. I mean, they're now in many ways ahead of us because they're so excited by it. So it's pretty exciting to watch. Next slide. So here's just a quick example of 2 of our investments. One is called the Creative Hub. On the top left, you'll see this was the old Boys and Girls Club in Worcester. You know, in the turn of the century, a little bit after, it was this vibrant meeting place in Worcester that everybody went to and knows about. It's been dormant for years and years. And 2 kind of innovative art teachers in the Worcester Public Schools put together a collaborative to reinvigorate it. And they raised a bunch of money. And they are creating what is, you'll see on the right, on the left side, it will be maker space for artists, and these are artists in the broadest sense, a lot of immigrant communities that have artistic skills, but no opportunity to show off their artwork. They'll be able to work together and collaborate. They'll be able to rent space at very low rents. On the bottom floor, there'll be activity space for children, for yoga and gymnastics. And then on the right side, it's all going to be event space. It'll be one of the only rooftop gardens in Worcester overlooking Polar Park. And all the revenue they generate from catering and events, they're going to pump back into the left side of the building. So we're really excited to support them on that. The bottom is a housing development in Fitchburg, Mass, as part of a larger development project. And it's across the street from the Fitchburg Art Museum. And the housing development is specifically giving preference to low-income individuals with artistic talent and ability. And they'll be able to come in a similar model, work with programs with the Art Museum, and really try to stimulate art in that area. So we're excited about that one as well. Next slide. Just quickly on hiring and purchasing, we had a goal this past year of hiring 20 new hires from the most vulnerable neighborhoods in Worcester. We achieved that goal. We hired 21. A lot of them helped out in our COVID testing and vaccination sites. We've made a goal of 30 for this year, and we're excited to do that. Purchasing, we've made a commitment to triple our purchases in minority and women-owned businesses over the next 5 years, and to change many of our practices to promote environmentally sustainable practices, and not only work with our general contractors, but also subcontractors on living wage and various other ways to support low-income communities. Next slide. This is just an example of some of the volunteering that I mentioned. You know, I'm a lawyer by training, and we had our entire legal department, among many other kind of back office functions, spent one day at a community harvest farm, and they basically picked and sorted almost 13,000 servings of fruit, which was the largest they've ever had. We've had people plant. We've had, you'll see there's a police officer for our organization gave out basketballs and footballs. So it's really inspired a whole level of engagement of our employees to want to get outside our walls. Next slide. So one thing we're thinking of is, you know, our effort is kind of broad in many ways, and we're thinking of trying to focus on a particular neighborhood that is one of the most impoverished in Worcester, and bring all sorts of other community partners in to help our investments and join with them and collaborate in a number of different ways, and to almost create kind of an anchor district and use it as a model to see if we can combine housing with other kinds of development and various businesses to kind of come together and help turn around neighborhoods. So that's in its infancy, but we're excited about the potential for that. And then I think my last slide is just to talk about a few of the benefits. You know, there's no question this is going to transform communities and lives. We think it's much more authentic to our mission, which certainly makes us feel good. It brings our community benefits, which I think you all know has always been a part of what hospitals do. It brings it to the forefront. It makes it very strategic, and it's now part of our overall strategy of the organization, and not just an appendage by the side. It improves our relationships with so many people locally, with residents, with city officials and state officials. And as I mentioned, you know, to me, the most gratifying part of this is just to see what it's doing to our caregivers, who have really stepped up. And so many of our ideas for this are coming from, you know, they're growing organically from all of our employees who want to get involved. So with that, I guess I will turn it back to Semra for our next speaker.
Great. Well, Doug, thank you so much for that. This was such an exciting presentation, and I can't tell you how much I appreciated hearing about bringing the arts in. I'm an artist myself, and I know many of my colleagues in healthcare are as well, including Dr. Bonica. So I think just recognizing that intersection of how the arts can be used to build community and how much that is part of your vision has been really exciting. And just the commitment that you have given is really amazing and exciting to see. Thank you for that. So I'm going to move on to our second panelist, Dr. Michael Swack. And Michael is a professor at the University of New Hampshire, where he has appointments at the Carsey School of Public Policy, as I mentioned, as well as at the Peter T. Paul College of Business and Economics. So we started a conversation about finance with Doug, and I think Michael Swack is really going to be able to fill in some other aspects of how to finance these kinds of initiatives. He directs the Center for Impact Finance and the master's program in the community development program at the Carsey School. And he has just done a lot of work on finance initiatives with community-based organizations and hospitals across the country. So I would love to turn it over to Michael Swack.
And Mike, you're muted.
Okay, let me try again. So first of all, thanks to Doug. That was a great presentation, and you're doing some really super work. And really ours is more a story that's in process as opposed to one that has all the results that you have so far. And it's really about aligning investments to improve population health. You've done that certainly with your own hospital system, and you've brought in others. We're really looking at a statewide strategy in New Hampshire. I've worked with, in particular, this idea came up when I first met Kevin Barnett about 7 or 8 years ago. Some of you know him from the Public Health Institute in California. And we were panelists together talking about community investment and hospital investment, and sort of hatched the idea that this is something that we could push. My background is in finance, and particularly community development finance. I'm the founder of the New Hampshire Community Loan Fund that some of you may be familiar with, still serve on that board. And I'm involved in a number of initiatives that look at how do we get investment into places where mainstream financial institutions don't invest. And often we don't have much government investment either. And so we conceptualized an idea for a statewide strategy after we worked in a couple cities across the United States together and contacted people from Foundation for Healthy Communities. Shawn, I think you were there at that point when we first talked and engaged the New Hampshire Hospital Association. At first around a discussion of our hospitals interested in working together on some of the social determinants in ways that Doug described in his presentation, addressing issues like housing and healthy food and even beyond that, a range of issues that affected people's health in communities. I mean, one of the first things is we did a series of events with that were sponsored by the Federal Reserve Bank across the United States was that really people were in silos, didn't talk to each other. There were a number of hospitals, many of them determined to address social determinants. And there were a number of community development financial institutions and community development organizations in particular, and they didn't talk to each other. I mean, we had a few situations where we held convenings at the Federal Reserve Bank where we set up tables of people from different cities and communities across the country and ended up introducing people who in many instances worked less than a mile from each other, their offices, and not only had never met, but in the case of hospitals, had never heard of these other institutions. You know, there'd be like $150 million community development financial institution investing in healthy food and affordable housing and supportive housing and that sort of thing. And they had never even heard of each other, and yet they had common goals. And so what we set out to do was to see, can we bring New Hampshire together? Like I said, this is a story that's in progress. So we don't know if there's a happy ending yet. We just started in January pulling people together and put together an advisory board that's comprised of a number of people from the health sector. We started by asking the New Hampshire Hospital Association to get signatures. I mean, pre-COVID, barely pre-COVID, but literally signatures on a piece of paper. Not electronic signatures either, they did this at their meetings, of a commitment to work together on a process where we looked at data and looked at how funds could be deployed and what it would have to look at, and not just short-term funds, but also long-term. A lot of the issues were long-term, and how we could tie into investments by public agencies as well. So for example, one of the things we're looking at in terms of how a fund would be built is how might it invest in telehealth and broadband in rural communities in New Hampshire. So we're also trying to tie in to some significant investment from federal government, state government, as well as private investors and the hospitals themselves. And in addition to looking at how to align investments to address those issues, looking to a shared policy agenda. Again, one of the really surprising things when we got people together is the community development people talked about legislation in the New Hampshire legislature around affordable housing and supporting that. something that in the last session lost by 6 votes, that when we talked to the lobbyist from New Hampshire Hospital Association said, wow, that wasn't even on our radar screen. If it was, we probably could have mobilized around it. So it was a lost opportunity. And one of the decisions this 18-person advisory board made is, it's not just about investments, it's a shared policy agenda to address those issues. So this is a key part of what we're trying to build through this strategy. Now, in developing the strategy, the hospitals were very clear that data is important. I mean, if anyone collects data, it's hospitals. I mean, for someone who works at a university, this is a dream come true. Well, not exactly, because the data is often hard to get. It's often accounted for somewhat differently, but there is a lot of data, and our commitment was to look at that. One of the things we really wanted to do was talk to people, though. The qualitative information actually is more important because, you saw it in the maps that Doug showed. That I hate to say this, I mean, it seems like, undercutting what a researcher might say, but in the quantitative data, which we looked at very carefully, nothing we found surprised us, nothing. The qualitative data, we actually learned a lot in terms of what are people looking for, what are possible places to deploy. I mean, if we take a look at, we looked here at quantitative, the PQIs, which all of you are familiar with, and various social determinants from different federal and state agencies. But what were the takeaways when we talked to hospital leaders and others? They talked about their priorities. Could there be projects? What were the policy opportunities? Here's some top priorities that came from looking at the numerous interviews that we've done over the past year. And this is important because what we want to translate that is to how do we deploy this to actual projects? How do we take the top priorities and look at what are the investment opportunities? And what are some of the options? So we know in hospitals that there's a community benefit, but that's going to be a limited amount. We know that some of them have endowments, others don't. That'll help. Some have land. I mean, one of the things we found out in our interviews where the nonprofit housing developer said, the issue isn't access to debt at this point, it's land. That's what drives up the price. We need land. Well, what we found was 4 different hospitals saying, we have land. We'd be willing to do long-term leases or even sell at low prices. So this was information we're able to find out because part of what we're doing is putting together a plan to say, what are the resources we need and how can they be deployed and how can public agencies align with us and how can we build a fund? Part of building a fund, though, was looking at the question of how do we build something that builds on what we already have and doesn't create something new? Creating a brand new fund is a high cost venture, and it involves a lot of operating costs. And what we wanted to do is build on what we had. So we've had discussions, for example, with the New Hampshire Community Loan Fund and the New Hampshire Community Development Finance Authority, both of whom have agreed at this point to collaborate to manage an investment fund, so that the operations would be more hiring people with specialized in understanding the health opportunities, and we've talked to several, and building a framework that really looks at investing money in the kinds of projects that address social determinants and not building a big new institution with operating costs. It's just some of the data, again, looking at poverty and prevention quality, overall composition. Again, nothing surprising. We know where poor people live in New Hampshire. We know in the cities where they live, just like Doug was able to show 2 miles away, the differences in indicators and life quality. The same things exist here. We are able to find the same information here. So what are we seeking to do? We want to develop a statewide fund that would include both donations and impact investments. One of the things we've seen in evaluating projects is not every project can pay money back. Some of them can, but some of them just need really deep subsidy if they're going to. So the fund we're looking at is one that would be able to make donations and impact investments. And in many cases, a blended approach. You're doing both. You're providing an initial subsidy, and it can support some debt, as Doug suggested, concessionary or low-cost debt. But what we also found in many of the projects that people want is it also needs long-term debt. Short-term debt meets certain needs, but if you're looking at longer-term solutions, you need longer-term financing and longer-term debt. We also wanted to look at governance. That is, how can we create a governance structure? So the New Hampshire Community Loan Fund has agreed to manage a separate fund created specifically addressing social determinants. And there will be an oversight body, essentially a governance body comprised of people in the health professions and hospitals, as well as community development and public agencies that would oversee the investments. And we would look to hire someone whose background is in public health, who will be supported by a number of finance people who already know how to structure deals, but don't necessarily know how to reach and deploy in communities around certain types of social determinants. So we're excited about the fact that we're putting many of these pieces together. We have a number of people who have agreed to serve on an oversight body. Many of them are on our advisory board right now. We have a state agency and a private nonprofit with a significant record of investment who've agreed to collaborate on creating this fund. We've begun to identify how the fund could deploy, both in terms of smaller short-term projects. What's the biggest problem? Well, the biggest problem in putting together a coalition, and I don't think Doug had to deal with this as much, is that the hospitals consistently say, well, if we contribute to a common fund, how do we know there'll be investments in our geographic area? And in many ways, this is a matter of faith. The idea is by creating an oversight body and an institution that's statewide, we'll seek, one of the objectives of creation of this fund is to broadly invest in all geographic areas of New Hampshire, including small rural towns, as well as cities like Manchester and Nashua. So this will be a challenge, but this is what we're asking in terms of, if you're going to make significant investments in looking at telehealth and broadband and things like that, it can't be one small rural hospital on its own. They simply don't have the resources to do it. We believe a statewide strategy is what makes sense for New Hampshire. And finally, we think it's really key, and there's been great cooperation from the New Hampshire Hospital Association, as well as many of the community development players here, to actively identify, which we've begun to do, a common policy agenda and advocate for that agenda at the State House, but also advocate for it in institutions across New Hampshire, so that when we talk about social determinants of health, it's hospitals, community development organizations, banks, public agencies, all with the same agenda. So that's what we're trying to do, and I will stop here and turn it back over to Semra.
Great. Thank you very much, Michael. This is so exciting to see movement on this in New Hampshire, and it's something that, as a public health professional, I have really just been waiting and hoping for so long. So it's wonderful to see what you've been able to do, especially in a very difficult year. So we'll return to you in the Q&A, I am sure. But I would now like to introduce our next speaker from Maine. And I'm delighted to have a panelist from Maine, since I actually live in Kittery. So I'd like to introduce Deborah McGill, who is the Senior Director of Population Health at Maine Medical Partners, which is a division of Maine Health. She has served for over 7 years in a distinguished leadership role, representing Maine's largest physician management organization. Working with system and organizational leaders, Deborah has provided the vision, strategy, and operational planning for Maine Medical Partners Population Health and Care Coordination Program. And I'm so glad I've gotten to know Deborah a bit as we plan for this panel. She's done some amazing and innovative work. And with that, I'm going to turn it over to you, Deborah.
Thank you, Semra. I'm so glad to be here. You know, it's interesting because I have so many connections to the University of New Hampshire. We have a lot of Maine Medical Partners employees that are alumni, and my daughter herself is an alumni, and I live nearby you. So this has been really great for me. Thank you for inviting me to speak tonight. And I guess I just want to start off by saying I really appreciated the presentations by Doug, and also the last presentation that we listened to, because what I'm planning to talk about tonight is really just a culture shift around understanding social determinants of health and why they're important to us. And I feel as though my presentation is a little bit of a narrower view of a culture change, but the two presentations that we heard earlier really are talking about a broad culture shift. And it's exciting to me because it makes me really confident that we're all starting to get it, right? So we're starting to get it as a country. I you know, without getting into too much debate here, I would say that the United States is a little bit slow and really kind of understanding and addressing social determinants of health, but I'm super happy to hear about all the great work that's happening. So I'm going to share a little bit with you just over the next 10 minutes about a culture shift within Maine Health. And so Maine Health is a large medical group in Portland, and well, it's in Maine. So obviously I work in Portland, but we actually cover quite a large demographic in the state of Maine. And we have, over the last several years, really been working toward moving to a place where we really understand the significance of social determinants of health and how they impact the health of our population. So this was, I do have slides. I think I have about 8 of them. And I want to say that these are more here as a reference for people after we leave tonight. I think we all really are familiar with what it takes to move a culture, what it takes to make a culture shift. There are many different phases. I think many different great leaders have written about this. I happen to quote one particular model of culture shift here, where there are basically 8 phases. And we start in a place where, you know, it's like, what is it that we're trying to change, right? People don't really understand what it is that we're talking about. And then we move all the way to phase 8, which is incorporating changes into the culture. So I'm going to think about this tonight as a culture shift around really understanding the importance of social determinants of health. So I would say that probably 6 or 7 years ago, and I would like to give us more credit than that. We probably deserve it here in Maine, but generally speaking, from my point of view, about 6 or 7 years ago, we really started thinking about social determinants of health and what they meant to our patients as part of their overall well-being. And so the first, you know, kind of 3 phases I've grouped into one question, which is, what are social determinants of health and why are they important to us? Why do they matter to us in healthcare? I remember discussions around, well, you know, we can't be everything to everybody, but really we can when we partner, right? When we partner correctly and we utilize the resources that are available to us, whether that is an anchor institution or simply a community-based organization in our town. So, and then stages, I think 4 and 5, are really just, we start to have some intermittent awareness. You know, people are starting to talk about it. People are really gearing up to buy in. And people who are excited to move on social determinants of health are really getting empowered to do so. And then the last 3 stages are really around widespread acceptance, investment, and action. And I would say that Maine Health is really in that widespread acceptance, investment, and action stage. And in Maine, you know, we have a unique situation because we don't actually have a very large public health infrastructure. And so the large health systems like Maine Health, Northern Light, and a few others have really had to kind of pick up the ball and sort of supplement those resources. So I'm very proud to be able to work in an organization that really recognizes and understands the important contribution of public health, and also how social determinants of health fit in. So I'm going to talk a little bit about how we at Maine Health are able to really start to understand and identify how our populations are experiencing social determinants of health related barriers. I think we all understand on this group, on this call anyway, you know, what they are and why are they so important. But there is a slide here that we show often to new staff and at other presentations that we get a chance to go to. But social determinants of health and why they matter, you know, they're basically like the slide we saw before. I actually took a snip of it because it was great. But it's, you know, 60-ish% of a person's well-being really has to do with factors that are outside of the healthcare system. And so obviously they're very important. But we also know that they impact a person's healthcare outcomes, which is obviously our business, right? So we really need to partner up with those organizations and resources that address these barriers and also really understand our populations in a way that we've never had to before. We also know, which is really interesting, and we haven't really talked about this yet tonight, but there are research studies now that look at provider experience and care team experience and provider burnout. And providers actually, you know, they carry a heavy weight, right? They care about their patients. And if they're worried that their patients are suffering because of social determinants of health related barriers, then that bothers them. And so to be able to feel confident that the health system has resources to be able to connect patients to get those basic needs met is really important. So it's a really interesting kind of recent studies that have gone on to really show the connection between provider burnout and being able to address these types of barriers for patients. So that's really interesting. So this really is just a slide about social determinants of health, not necessarily about culture change, but it really is a huge driver for some of the work that we've done at Maine Health. So in phases 1 through 3, which is really that sort of intermittent awareness, you know, why is this important? You know, one of the biggest things I'd say that we did at Maine Health is to establish a means for our care teams and providers, our care coordination staff to be able to actually document in the medical record where some of these barriers exist in our populations. It's important because it helps us assist them, but it also helps us in many cases understand where there are gaps. So, you know, the work that's happening with the Anchor Institution in Massachusetts, the statewide coalition in New Hampshire, those are really encouraging because, you know, what we want to do here as a medical community is really plug in to those community resources. And so being able to document some of the barriers that patients face in our medical record allows us to have analytics, right? So we can look at the number of times that someone has a barrier, the number of times we've been able to connect them, and then those times when we haven't been able to connect. And so what's missing in our community. So as part of the kind of culture shift, when we were in a period of intermittent awareness, we were able to actually leverage our medical record to be able to document these data variables. The other thing that we were able to do was partner up with a social services platform. It's called Aunt Bertha. I don't know how many of you have heard of it. It's kind of a funny name, but it's a catchy name. I'm actually sad to find out they're changing their name. They're going to be called findhelp.org. I think Aunt Bertha is better because people are like, wait, what? Who's Aunt Bertha? But anyway, Maine Health was able to leverage our medical record, number one. And number two, we bolted on with this Aunt Bertha platform, which once we identify that a patient has a need, we need to be able to respond to that. So I would say in our early phases of awareness, those were the two major moves that we were able to make as a health system. It's been exciting to kind of hear not just frontline staff talking about social determinants of health, but we're also hearing about it in our board meetings. We're hearing about it at a lot of our senior administrative meetings. And so I feel at this point that intermittent awareness has really kind of progressed. So that's kind of where we started out. I would say, you know, when we first were able to document social determinants of health in our EPIC medical record, that was probably in 2017, 16, 17. And the Aunt Bertha platform we connected to in about 2017. So the next step or the next few phases of culture change are really sort of spreading the awareness, getting people to buy in. And so there was a small kind of core group of people that really pushed for this Epic upgrade, for this Aunt Bertha platform. But gradually over the last few years, we've noticed that there's more and more and more buy-in, which is very exciting. So one of the first phases of people who bought in, if you will, are care managers, which is probably no surprise, right? So care managers are people who support our high barrier patients in making sure that they can access the healthcare that they need. So it could be anything from providing transportation or affordable medication, all the way to finding housing for people who are experiencing homelessness. So care managers were quick to buy into kind of the social determinants of health culture, if you will, and also really using the tools available to us. We started off with that group. I've got some acronyms here in this slide, and so I apologize for that. But over on the left, the care managers, when we first started using the Aunt Bertha platform to respond to social determinants of health-related barriers, we actually had an annual improvement priority, which is what AIP stands for. So our hospital and health system actually thought enough of this work to put it in their strategic plan. And so what they did at first was to hold care managers accountable for assessing, documenting, responding. And then over the years, we've actually expanded that now beyond just care managers to also primary care providers and others in care coordination roles across the system. So Maine Health is a bit of a complicated health system, but what I can say is, you know, we have, I'm sorry, I'm blanking now on how many actual providers we have in the Maine Health system, but it's in the thousands, of course, and then care team members as well. So we've got thousands of people now, every time we talk to a patient, actually getting comfortable asking them, what are the barriers that you're facing and how can we help you? So I think that the fact that it has become part of our strategic plans, part of our operational excellence, which is our lean daily management system for quality improvement, really speaks volumes about how dedicated the state of Maine and the Maine Health System are to kind of addressing this kind of work. And then the final phases really of culture change are widespread acceptance, right? So are we making investments? Are we taking action? We're normalizing the discussion around social determinants of health for providers and care teams with their patients. It's no longer something that we worry about asking. We do recognize, obviously, that it's private and personal, and unfortunately, there can be some shame associated with social determinants of health-related barriers, but we've really worked in several processes to be able to circumvent some of that shame, if you will, where we've got patients who can either anonymously fill out questionnaires in their MyChart, or potentially when they come in for a visit, we let them use a dry erase kind of assessment so that we erase their answers once they leave, but really making sure that we're comfortable talking to people about what is it that is getting in your way of living your best life. It is not okay that there are these equity disparities across communities. I think, Doug, you know, when you presented earlier, that 2-mile difference in geography, it's just stunning and really sad, but real. And so being able to make sure that no matter where you come from, you're able to have an opportunity at least to ask for some help or to have people recognize that you might need something. We do ask permission of all of our patients to discuss these types of barriers, especially in the pediatric realm. We don't want, you know, obviously children, they can't always speak for themselves, but with the parental relationships or the guardian relationships, just really try to ask permission, because we want to remove, you know, a lot of times or traditionally healthcare has sort of been like, here's the provider and here's the patient, and there's this sort of unequal relationship, and we're just really trying to normalize that. So making sure that we're giving respect and privacy to people to discuss these sensitive topics is really important, and we have worked hard in these phases to make that happen. We've done a lot of training in trauma-based care, trauma-based interviewing, and so really listening and just not being judgmental has been really important. And then collaborating with patients and families instead of acting as though they're helpless. You know, what is it? You know, what's the most important thing to you right now? Is there something we can do to help? And then making sure that we're giving them a choice, right? So, you know, this isn't this anymore, it's this. And that's been really amazing to watch. I would say that in a health system in particular, physicians are very important in helping us to change the culture. And we have some wonderful physician champions here in Maine that have been able to help out with a lot of this work. So I want to be conscientious of the time, but what I will share here, and this is really just for visual, with the Aunt Bertha platform, the social services platform, you can see over time, we have really increased the utilization of that platform. You can see the blue line, that's care manager use or anybody with a care coordination title or role. Over time, you know, we have increased from a 19% usage all the way up to 100%. So that means 100% of the care managers make at least one connection every single month. And then we've brought our providers and care teams up to around a 35 to 37% connect rate. So that's really a big deal, really making sure that we're asking the questions and then we're doing something about it. And then I just want to share really quickly, we've talked a lot about different social determinants of health, but one that doesn't get a lot of press, at least in conferences and such, is really diapers. I'm just going to put a plug out there for one of the successful partnerships that we have had with this work, which really speaks to the awareness and the buy-in, is that as we started asking questions, we really saw a huge need, not only in care affordability, transportation, and food, but diapers. And people with a lower income, especially if you go 2 miles over, right, you see the 37% of median household income. People, the lower your income gets, of course, the more you actually have to spend, the more of a percentage you have to spend on diapers. And so this is a huge problem. So one of the early successes we had was with a diaper bank. And they're in the Aunt Bertha platform. We can refer to them electronically. We can keep track of how many patients we're helping. And I would say that what makes this more of a success story than just providing diapers is that as we were working with this particular diaper bank, they happened to notice the correlation between hunger, of course, and diapers. And so whenever patients or families come in to get diapers, they actually can go shopping. So they get to go shopping in the food pantry along with the diapers. So it's been a really nice partnership, you know, with the diaper bank, but also with several communities, community organizations over the last several years. I believe we have added over 700 programs to the Aunt Bertha platform for people to access in the state of Maine. So it's been really wonderful. We as a healthcare team can access the Aunt Bertha platform and help patients, but they can also self-serve. So in our My Chart, also on all of our websites, we have a link. You see this particular, where is it? Oh, right here, the need a little help icon. So if a person needs a little bit of help with any one of these resources, they can click on the link and serve themselves. So it's really been an honor to be part of this process here in Maine, and really excited to kind of be here tonight to just showcase some of the work that we've done and to hear some of the great work that others are doing. So that's it for me.
Deborah, thank you. That was wonderful. And what I loved about your presentation is taking us down to the very personal level, because you reminded us that all of this work, which is about changing population health and the health of communities, but like most things in life, it boils down to connections and personal relationships and just that very personal story of changing the culture. Thank you so much for sharing that with us tonight.
You're welcome. Yeah, just really quickly, if I could, when you said that, it made me go right back to, March 17th of, I think, 2020, when the world shut down, right? This On Bertha platform was such a lifesaver for us, because what we were able to do for our patients and our care teams was to be able to make real-time changes in program availability. A lot of places shut down, and that's unfortunate because people still need things. So it was a real eye opener for us, how much we depended on this collaborative work, between the health system and the community resources. So it's been a wonderful, I guess, in a time of turmoil, it's been a nice, bright spot for us to be able to continue to help people.
Well, your enthusiasm is contagious. So thank you so much. Contagious in a good way for a change, right? So I would love now to go on to our fourth panelist, Shawn LaFrance, who is the Vice President of Population Health at Cheshire Medical Center, right here in New Hampshire. And I was chatting a little bit with Shawn right before we started the panel, where when I first came to New Hampshire to start my position at UNH, I saw this amazing document called Vision 2020, which was one of the strategic documents put out by Cheshire Medical, which really, way before all of the social determinants of health conversation really got going, laid out this wonderful plan of holistic community building. And I shared it with all my students because it was just a wonderful way to showcase that. And I understand that this has evolved, and Shawn is one of the people leading the charge there. So I would love to turn this over to Shawn. I think Mark Bonica is going to be advancing the slides for Shawn, but Shawn LaFrance, you're up.
Shawn, you're on mute.
Hi, sorry. I think the presentations are so connected. I'm really excited about this. And I feel like we started out hearing about Worcester and what Doug was talking about. And this end of it is really the rural perspective on some of these issues. And particularly my focus is on social determinants of health. So this first slide just gives you an idea about the rural area that we serve, which is that shaded corner of New Hampshire. You can see our hospital on one side and the iconic Mount Monadnock, second most climbed mountain in the world, according to the statistics, I guess. And it's a region, as I said, it's very rural. There's about 76,000 people, and we've been losing, sadly, population with the most recent census data. And then it's also interesting, a positive and negative, if you will, is that it's the natural and built environment, both natural, and when I say built, I'm talking about these picturesque little towns with white steeples and picket fences, make this very charming. It does not have 1 mile of interstate highway or divided highway within the whole region. And in fact, it's about the closest one, you either go to Vermont or you go about 45 minutes east of here to go to 89. So it really preserves our area, but it really introduces some challenges from social determinants of health and just understanding the region. Because if you visit it, it can look, as I said, quite nice, although our work has delved into the disparities once you look at the population deeper. Next slide, please. So I put this up here because I'm just really tagging what Semra was saying earlier. So this is the website for what is now called the Healthy Monadnock Alliance. What Semra referred to as the Vision 2020 was started in the year 2006. And it was a very bold or audacious goal that we would become the healthiest, I should say, community in the United States. And that kind of goal and framing brought lots of people together over a multi-year process to understand really what is health, which was like social determinants 101 that went on in this area for a few years, and then evolved until we had Healthy Monadic 2020, which wasn't a huge celebration because we were in a pandemic. And now we call it the Alliance, partly because we want to spread the ownership more in this Alliance format. And you'll note there's no end date, if you will, because community health improvement doesn't have an end date. It's something that we are all constantly trying to do. The roots of this work, though, I think why it is what it is, I guess, in this particular organization and region, goes back to 1994, when the leadership of this hospital created the Council for a Healthier Community. It had elected officials both at the county and municipal level. It had the local Chamber of Commerce, both public education and some of the higher education folks in the region. And that started a group talking about how do we do health and how different things influence health. That entity, the council, continues today as what's called the Leadership Council for Healthy Monadnock. That is something that came into being when the state of New Hampshire 7 years ago created public health networks. And since we had already been doing a lot of this work, Cheshire Medical Center was contracted to be the public health lead agency in this region. And so there are some deep roots, I think, in terms of the kind of work we're talking about. Next slide. So the culture, Debra was talking about culture of change or culture in the organization. And so that is deep, I think, in our area. And back in the 2018, there started at our board level discussions about issues related to diversity, disparities, if you will, in terms of the population health in our region, recognizing that the diversity, led to quite a few disparities, and that a lot of times when people looked at the surface, whether it's the data or drive by in your vehicle, that everything looked quite well and good, but we knew that there were pockets of poverty and need that were unnoticed, if you will. And so the board made a commitment that we put a big emphasis on equity instead of equality, the more familiar term. And so that's been guiding us since 2019. Next slide, please. The Center for Population Health, which is the department I have, it used to be the Community Health Department, and their principal role in those days was to be more a tool to communicate and offer community health education classes and things like that to make connections with the community. So it was reframed because as the Center for Population Health, we're not only doing health education, if you will, but also doing much higher levels, if you will, of understanding our population and building connections within the organization and externally. And Prescribe for Health is a program that we started 5 years ago where we employed community health workers who are linked as team members with our primary care. And they work with providers who might identify somebody, particularly people with chronic disease, who could encounter barriers to following through on the recommendations of the clinician, can get a referral to meet with a community health worker and address some of those other barriers. And we found that to be quite fruitful and in terms of making improvements. Next slide, please. So I love this image because it's really this idea about going upstream. And so I think the traditional medical interventions are at the lower part of this image. The individual impact is what I was just referencing, the notion of working with patients or their families, whatever, to address social determinants of health. But the larger upstream piece is really starting to look and address policies and other factors. And we had early experience of that in Keene, New Hampshire, because in the early 2000s, the passed a municipal ordinance that banned smoking in restaurants in this community. This is long before state and federal law happened. It set off, it was a groundswell at the local level to do this. It set off a challenge that went to the New Hampshire Supreme Court that overthrew the ordinance because of the not separation of powers, but there's a constitutional issue that was at stake. In any event, that was remedied when new laws were put in at the state level that preempted whatever the city was doing. I must add that all the restaurants maintain their no smoking policy, even when the court ruled it not valid under the ordinance. So that was an early policy thing. Other areas that we work on, we know that physical activity and mobility, transportation is big in rural areas. We have adopted complete streets policies, which is a transportation policy framework. We have the largest number of municipalities in the state and Cheshire County that have complete street policies that promote physical activity, access for disabilities, etc. The other thing that food insecurity is a really important problem. It's becoming more and more recognized. And one of the ways that we've been focused on that is particularly investing some of our community benefit funds, if you will, with the Cheshire County Conservation District. So that has supported increasing capacity of local farms and developing distribution channels and transportation to get local, healthier food more affordable and more accessible to people in the region. So a few examples of how we are trying to push that envelope or push it upstream. Next slide, please. And this is the image I think many of us are familiar with. And I do want to circle back, since we've been talking so much about the 80% of social determinants. We do pay attention to the healthcare outcomes, and our data shows under the Prescribe for Health program, we've been tracking people with diabetes since it started. And we've been able to document through EPIC, which is our medical record, measurable improvements in the A1Cs for people who have been served through the Prescribe for Health program. Next slide. All of this work is embedded in our community health improvement plan that the hospital uses as part of its annual improvement plan that we do everybody at the hospitals do now under the ACA, but also this is done at the community level in the public health framework. And if you look in the middle there, you'll see equity, social determinants, and actually trauma are the three core things. And the 5 other circles represent the work groups that are addressing various priorities. Next slide. One example of that is the healthcare access work group. So transportation is a big problem I mentioned. And in the healthcare workforce area, we've really been investing, similar to the Conservation District, we've invested in the Community Volunteer Transportation organization, which is a nonprofit where we have invested dollars to allow them to expand, recruit more drivers in this more western part of the Monadnock region and build up capacity in that way. But in addition to that, as I said, the other areas, we just try to link these various issues such as transportation, because we know social connections are a big issue, and in health, particularly when we have an older population in this region, as well as the complete streets and other issues. And lastly, next slide. All of this work, I was kind of being maybe a little narrow talking about Cheshire and the Monadnock region, but we, kind of embrace the larger framework that we're particularly fond of, that Robert Wood Johnson's culture of health. And, we're aiming for that diamond in the middle, but we're touching all 4 that encircle it. And I think that's been helpful in our journey. Thank you.
Great. Well, Shawn, thank you for another wonderful presentation. And I think especially bringing the rural perspective in is so important, because it's challenging to do this work. And the research that we have is predominantly reflecting urban or suburban spaces. So you are literally providing lessons learned for other places in the country that are more rural, and there are many of them. And there isn't as much research or even just practical lessons that have been shared. So this work is really, really valuable. Thank you for sharing this. I'd now like to open it up to questions. So you've had a chance, audience, to hear from these 4 amazing panelists, and we would love to take some questions now from the audience. There are a couple of them in the chat. So actually, maybe I will read the first one because I noticed it came in a while back, directed, I believe, at Debra because it's about Maine, but I think this question about food access could very well apply to every one of us. And the question was, does Maine Health, or any of us, use the vital signs of hunger, which is a 2-item screening tool, to identify those who are at risk for food insecurity? And if you don't use that, maybe there's another mechanism. So that question of food insecurity and how we use systems to identify those at risk and how we address that.
I'm happy to start off, I guess, since the question was about Maine Health. And we actually did incorporate the vital sign of hunger into our social determinants of health assessment. In the medical record, we have a few additional questions around food security in our assessment, but yes, we do. And I think one of the unique things that we're able to do, it doesn't solve a problem, but it meets an immediate need, is when somebody screens positive for food insecurity at our clinics, we have food bags. And so we can give them a food bag that, again, it doesn't solve the problem for sure, but it gives them some food for, I believe, 48 hours. And then we connect them to a local food bank. So, so long answer to a short question. Yes, we use that vital sign, and we have a few additional questions so that we can make sure they don't leave our office if they don't have any food to eat that night.
Thank you, Deborah. One thing I noticed so much from your presentation was connecting data to action, which is another thing that I remember when I would talk with folks when this work was first beginning. People were collecting data, but managers were saying, we don't really quite know how to feed that back into care improvement. And it really sounds like there's been movement in that direction, which is so exciting. So now not only collecting data, but really using it to transform lives. Very cool. I would like to ask if any of the other panelists want to talk about how they address food security. And then I have a little plug for some of my partners here in New Hampshire who are addressing food insecurity as well. But let me ask Shawn or Doug, perhaps, if you have special things that you would like to say about food access.
We have, I would say over here, we have switched to using those questions. We weren't when we first started our Prescribe for Health program, but we find them, focused and very helpful. Similar to what Deborah was saying, well, we have in addition to what I was mentioning earlier about really trying to invest in the infrastructure of healthy food within our region, since it's rural. We also have a program where we've been able to expand access to EBT at the farmers markets in the region. We also have set up CSAs for some of our patients who want to take opportunity to do that in the summertime. And so these are provided not without a cost to the actual family that does that. And yeah, so and the other thing we do is we do give out food cards. Particularly we find certain times of the month, there are certain patients who are dependent on their check from the Social Security, I think, and such. And so we have a program to help deal with that.
Yeah, great. And Doug, anything you want to mention? I know you talked about gardening and local food is a question that comes up a lot too, for both the health promoting benefits and the concerns about climate change and local sourcing. So is there anything, Doug, that you want to mention in relation to food and perhaps how you work with local food sources?
Sure. Yeah, we think about this a lot. We've had a veggie mobile in place for a number of years that goes into all different parts of the city to deliver fresh foods. We've got a number of community gardens that we've had throughout the neighborhoods to try to get local residents to really understand and learn about gardening and healthy foods. We've partnered with a lot of food banks in the area. And one of the most exciting things we're doing now is we're standing up a food as medicine program, which we're in the process of doing a food pharmacy, basically. So we'll have tailored meals that will address specific medical needs. So we're starting as a pilot in our cancer program, where there'll be medically tailored meals that will be specifically designed to target cancer patients. And so we'll give them access to fresh foods when they leave their visits. And we're really excited about that. So it's a critical area. And one of the things we're hoping to do eventually is a rooftop garden on one of our buildings. So we haven't quite been able to pull that off yet, but we're still working at it. And
Those are great
we do
examples.
those screening questions as well, among others in the social determinants of health screening tools.
Thank you so much. And I just wanted to make a really brief, plug for my wonderful partners at UNH Cooperative Extension, who on the aspect of food insecurity have created an interactive tool called the New Hampshire Food Support Site and the Food Access Map. And I did put it in the chat, so we won't have to take up a lot of time. But if any of you work in New Hampshire, including attendees, please look at the chat. There are a couple of links there where you can access the map. This is ready to use for your clients or even anyone in your life who might be facing food insecurity issues. And there's also a little survey that we would love to have you fill out because we're trying to improve the map. But I want to move on to some other questions. Mark Bonica, do you perhaps want to mention one from the chat?
Sure thing here. We've got Robert asked, the COVID crisis has caused a tremendous increase in the demand for mental health and substance abuse services. The climate crisis is likely to cause an even larger demand. What are hospitals doing to be prepared to be able to respond to this?
I'll take a shot at it. One of the things that we do is every 3 years or so, we work with the UNH Survey Center to do a random digit dial survey of the population in our region. And to your point, it is dramatic because last September, we did that survey and we saw, compared to 2017, the time we've done it before, a doubling in the number of people who responded to having 5 or more days in the last 30 days where they experienced severe mental illness. And so that has been exacerbated, of course, by the pandemic. A couple things that we're doing is we've just opened more services, if you will, particularly related to the substance use problem. New Hampshire was one of the sadly top 3 states in the country during the opioid epidemic, when the federal government passed the legislation to create some funding. And so we've been able to stand up what's called a Doorways program, which is an open door. It has 24/7 access to a clinician. And we've just been serving, well, we're over 100 new patients per month now. It's about 2.5 years old now. And so part of that gets into social determinants, because one of the things we quickly realized is that several people that were seeking help were homeless. So we were able to purchase beds at the local shelter, which that sadly steady stream of income for them has allowed them to stay open year round now, because before they were much more dependent on intermittent funding. In terms of the climate issue that you raised, we did a study about that in the region and then engaged the community in some conversations. The study was kind of scientific in the sense of looking at a wide range of things, like why Lyme disease is such a problem when it didn't exist here not long ago. But the biggest thing that the community focused on is the issue of severe weather events. So we've had a couple floods, we had a severe ice storm, and we are applying the social determinants lens in terms of that. And so what we've been able to do is work with partners. We've documented where people live at risk of flooding because of streams and rivers. We've surveyed that population about what their expectations are for help. Found out most people think somebody's going to show up in like 3 hours to save them, which is not going to happen. And so we've got an education program going and having people develop kits where they have like 3 days worth of food supply and educating vulnerable population groups. We've also documented who owns vehicles or don't, because sometimes it's elderly folks living in these older homesteads, and their mobility is not so good if there was a flood or a severe winter storm. So a few things just trying to adapt with climate stuff.
Thank you. Those are great examples. Any of our other panelists want to share anything related to that question, mental health and the syndemic risk that we're facing with COVID, chronic disease, ongoing epidemics, and climate change?
I'll,
Go ahead, Doug.
Sure. Okay. I'll just hit it quickly. I mean, I think it's a great question, Robert. Those are two of probably the most significant issues we face now. I mean, the behavioral health problem was a crisis before COVID, and now I don't even know how to describe it. We've had children who have been in our emergency room for like 40 days because there's absolutely no place for them to go. It is so tragic. So we've done a lot of what Shawn described. We partnered to open a new behavioral health hospital in Worcester to add capacity. Harrington Hospital, I just mentioned, that we acquired in July, just opened about 20 new beds within the past few weeks as part of an incentive from the state. That'll help. Our behavioral health provider has got one of the only kind of urgent behavioral health care programs in the state where individuals can come in with all sorts of problems, and we treat them and get them to the right place. That's been effective. But it is just such a huge problem. I think it's going to require more significant effort at the state level and more funding, frankly, and more capacity. I wish we could solve it tonight, but we won't. You know, the environmental thing, I'm on the American Hospital Association board, and this is now got to be part of our strategic agenda. We've got a retreat in January. It's an item on the agenda. And just as you say, it's a big deal because hospitals contribute. You know, at UMass Memorial, where part of our purchasing commitment is to have only like 50% of all of our new vehicles are going to be alternative fuel vehicles by 2025, I think it is. We're going to buy more electricity. I think we're now at about 20% from non-fossil fuel sources, and a number of other things. But I think it's a big deal, and we've got to lean into it for all the reasons you say. Thank you.
Thank you. In the interest of time, I want to invite one of my MPH students, Madden Kenny. So Madden, if you can hear me, Madden is actually going to read a question that was shared by another colleague and friend of mine who's a social worker who's also quite concerned about climate and mental health and our well-being during these times. So Madden, if you're able to unmute, would you be able to read the next question, please?
Yes, hopefully you can hear me okay. I've had a little bit
Great.
of connection issue. So the question is, over the last decade, there have been numerous assessments on the impact of climate change on human health. As a major employer and healthcare provider, what has your organization done or planning to do to reduce the impact of climate change on the communities you serve regarding their physical health and mental health?
So Madden, this is Deb McGill. I'll try to give it a shot. I appreciate the question very much. And I guess what I would say is this isn't necessarily addressing social determinants of health directly, but it certainly is thinking about the environment. And so at Maine Health, we have, started to put together work groups, committees, interested parties to kind of figure out ways that we can contribute to helping, and being more conscientious of our impact on the climate. And so we range anywhere from reward programs for people to commute to work, more walkable pathways between our garage, let's say, and our hospitals, making sure the pathways are lighted so people can walk, partnering with cities and communities to be able to make the neighborhoods more walkable for people who are either walking or biking to work. We also have recently instituted a project where all of our computers, not all of them, obviously in the hospital, but administrative offices and things like that, the computers shut down for certain hours overnight to try to reduce power consumption, doing a lot of buying local and really trying to kind of help in small ways, if you will. But it's definitely something that has really garnered a lot of people's interest over the past couple of years at least. But over the past several months, really seeing some concerted efforts on a larger scale to start to encourage people to be more conscientious, besides general things like recycling and stuff like that.
Thank you so much. Mark, is there anything else in the chat that you see that you want to voice?
Sure, I'll try to summarize Kyle's question here real quick. She asks about the moral distress of caregivers who are concerned about policies and programs that would help their patients with the identification of interventions that could address barriers and gaps. So where do panelists think researchers and analysts can be most helpful in furthering the conversation about, I think, identification and removal of barriers and gaps?
I'm just going to say that's an amazing question. I'm going to let the other panelists maybe kind of jump in before I do, since I got to answer the last question, but thank you to whoever posed that.
Yeah, I mean, I'll take a stab. We have the Aunt Bertha program that Deborah mentioned as well. We've probably had it for, I think, 2 or 3 years, and we found it really effective. And I think one thing we've observed is that caregivers are particularly frustrated when they hear about these other needs that their patients are experiencing but have no way to solve them. And so Aunt Bertha has been an amazing opportunity. We've branded it as community help in our community. So no one knows Aunt Bertha, but that's actually the platform. And really once the providers understand that there's actually a resource to make referrals, it's really helped a lot. And I think that's probably the single most thing that we found is a way to address some of those gaps for providers that's been really helpful.
Yeah, I would just comment in our area, what you're raising is a really important question. It's something we wrestled with because there was a state Medicaid waiver that was requiring us to screen patients in certain with a whole set of questions, and it was identifying a lot of problems, but there was like sort of nobody to respond, and that really did upset the clinicians because while some people argued that the collection of the data in of itself helps policy advance and change, and you can make that argument, but I think at the clinical level, people were really uncomfortable with asking people and then having people identify like significant issues and having nobody to deal with that. So we've partly been able to expand our community health worker program and such related to those, what you're talking about in terms of the two approaches coming together.
Yeah, I think an interesting area of research would probably be around sort of what Doug and Shawn both mentioned, which is, resource availability and or the lack of in various communities, especially in states where there are strong public health infrastructures as opposed to those where there are not. I think morally speaking and ethically speaking, it is such a challenge for healthcare providers to be able to every single day, see people who have needs that we can't necessarily solve for them. So really understanding the link between community health infrastructure and not. And then, there has been some interesting research, I think I mentioned earlier, around, care team and provider burnout and the ability to be able to address these things for our patients because obviously we're in this field for a reason, right? We're all compassionate people. And so what kind of an impact does that have on, movement in and out of healthcare delivery, positions, even in careers.
Great.
I'm in awe of researchers, actually. I'd love to sit with one for a whole day and just say, I want to know this, and this.
I think you've just scoped out a wonderful PhD thesis here for somebody. So stay
Deborah,
tuned.
there are other issues too. I mean, the environmental and climate justice movements. We just did a paper here at Carsey, a white paper on the impediments to financing clean energy in low and moderate income communities. And there's this whole financial component to it. The tax laws are written in such a way that the state laws around compensation for generation of energy. I mean, there's so much misalignment. And of course, the outcome is that poorer communities are more environmentally challenged. The Build Back Better has a lot of money that would go towards environmental justice and financing projects, and even getting around things like, where the only subsidy is a tax credit, which isn't very helpful if you're lower moderate income. And if you develop affordable multifamily housing, you usually don't pass that on to your tenants. So I think there are a lot of potential opportunities, which we point out in our paper, and some real opportunities to, scale up, for example, clean energy investment in poorer communities, which is really needed. It lags, everywhere else, just like every other indicator, right?
Thank you, Michael. I think this discussion of connecting social determinants of health to environmental justice, climate justice, and really just mobilizing the voices and the hearts and minds of healthcare professionals and our partners is both the challenge, but the tremendous opportunity. And it's the hope, I think, that we can all probably leave this evening with and move on with. So I want to take the opportunity to thank every one of our panelists. It's been an amazing discussion. I want to be mindful of time. People I know are busy, and everything that you have shared is just, I think, a tremendous learning opportunity for our students as well. I want to thank our students who made time to attend today as well. You are valued and you are going to be our future. So thank you for being here. And with that, I will probably leave it to Mark to close us out tonight. Thank you so much, everyone.
Well, thank you, Semra. Thank you to Doug, Michael, Shawn, and Debra for joining us tonight. What great points of view from all around here, Northern New England here. Thank you all, everybody who participated. I hope you found this valuable. We do, the chapter does training and presentations like this fairly regularly. So I've got your emails. You may hear from me again in the near future as we do that. So thanks. And also thanks for the support from ACHE. And I'll turn it over to Ricardo to close us out.